Introduce our speaker for today, Dr. Paul Morton. He was born and raised on Big Island and went to the Johnny Burns School of Medicine. He then did his orthopedic surgery residency in Pennsylvania and did a fellowship in adult reconstruction at the University of Chicago. He also did an AO trauma fellowship in Berlin, Germany. His focus is on joint replacement, joint preservation, and salvage procedures. He currently practices at the Island Orthopaedics Waialae office, the Queens Medical Center West, or the North Hawaii Community Hospital. And he's also a clinical instructor for the Orthopedic Surgery Residency Program. Please welcome Dr. Paul Morton.
All right, thank you for having me today. Thanks for sharing your afternoon with me for a little bit. I just wanted to cover some topics today on some common orthopedic issues that I see in the elderly. First off, like we said earlier, have no financial disclosures that I need to make. So again, I wanted to go over the management of geriatric fractures and treatment options. These are pretty common. Go over some of the preoperative workup and some of the postoperative management of these patients, and really discuss some of the common injury patterns we might see. And then I also want to go over some of the common problems you might find in older individuals with aches and pains. So first off, I'm going to start off with geriatric fractures. I think this is something that, I cover trauma care at 4 different hospitals in the state. So I see these a lot, and it's probably one of the more common things that we see in community hospitals. So first off, the elderly population, I'm sure all of you know, is something that's growing, and so we're going to see a lot of these. And so really the big takeaway points is that osteoporosis is very common in the elderly. There's over 2 million fractures that occur secondary to osteoporosis every year in the US, and 1/3 of people over the age of 65 fall at least one time per year. So it's a pretty common thing to see after people are falling, and so we have to be pretty careful in patients who have osteoporosis. The female to male ratio for osteoporosis is there's 4 times more women have osteoporosis than men, which makes sense because women live longer, although men are more likely to have secondary osteoporosis. The 3 most common other types are hypogonadism, alcoholism, or glucocorticoid excess. There's a few different types of osteoporosis that are really important to take home. Is postmenopausal osteoporosis, and you'll typically see fractures that occur in the ages of 50 and 70, and then senile osteoporosis, which is definitely more common in the elderly and is common in both men and women. And then secondary osteoporosis can occur at any age and is probably less important to this conversation. So as you know, there's 2 different types of osteoporosis. There's postmenopausal and senile. I think the important thing to note is that when we're talking about senile osteoporosis, we're talking about that it affects both the cortices and the trabecular bone. And so the trabecular bone is really the bone that's within this box. If you look at, say, the vertebral bone. Now, the box is the outside is the cortices, whereas the inside is all trabecular bone. And so in postmenopausal osteoporosis, the inside turns from this to this, where the bone becomes weaker and a lot thinner. Whereas in senile osteoporosis, the construct on the outside, the thicker bone, tends to actually become weaker. And as a result, the types of fractures that you're going to see are different. And so vertebral fractures and wrist fractures, distal radius fractures, the type of bone that's in there is typically more this trabecular bone. And so that's why you'll commonly see that. Whereas in senile osteoporosis, these are weight-bearing areas in the body. And that's why you start to see more fractures that occur in weight-bearing areas as you get older. You might check calcium levels on these types of patients, and you'll probably see poor calcium absorption in senile osteoporosis, and it's less common in postmenopausal patients. Vitamin D is also something that I think is important to make sure that we pay attention to, because a lot of our patients have decreased vitamin D levels. Risk factors to osteoporosis, it's a lot of things we can control are things that are involved in lifestyle, sedentary, smokers, poor diet, or premature menopause. There's some medications that a lot of people need to take for other reasons that can be associated with osteoporosis, as well as some genetics. And then any chronic diseases also play a role. But I think focus on some of the things that we can control, such as diet and sedentary lifestyle, can help with improving bone quality in patients. So typically, when patients present with a fall, with some type of broken bone, I think it's important to make sure that we're looking to see, is this from a fall? Did they fall down and pass out? And so evaluate whether it was a syncopal episode or was there abuse involved. And I think when you take a history, it's important to know if they were walking or not walking, and if they were walking around the community, because that really determines some of the treatment that we'll be doing. And so paying attention to how people were before they fall can help us with taking care of them afterwards. I think taking into account some of their, how many medications they're taking, if they're on any anticoagulation, and then also taking a look to see if they had bisphosphonate use, because sometimes the use of this particular type of medication can lead to certain types of fractures on one side of the body, and usually we'd like people to stop taking it if that occurs. We talked a little bit about different types of fractures. So distal radius fractures tend to occur more in postmenopausal age, 50 to 60. We start seeing spinal fractures between 60 and 70. And then at the time when everybody has senile osteoporosis, you start seeing hip fractures start to be more common in those over the age of 70. And most commonly, you actually see more spinal fractures and then hip fractures and then wrist fractures in terms of how common these injuries are. When we're working up these patients, it's important to take a look at the x-rays. And I always advise people to get x-rays of the joint above and the joint below, because that determines how you're going to be able to fix this. If you just took the x-ray over here, you'd see this kind of faint line fracture line here, and you might think, oh, maybe I can just put in a rod and stabilize the whole fracture. And little would you know, you've got this disaster hiding down below. So I think it's important to take a look to see if there's a knee or a hip. I mean, whenever you're looking at fractures, if you take a look at the knee, also make sure you look at the hip and vice versa. So when we're trying to treat patients, I think having a good history helps you determine how you're going to treat patients. Sometimes we elect for non-operative management, and that really depends on their medical comorbidities, their desires, and what people are trying to look out for from outcomes. And really, it's about pain control and ease of transfer with these patients. Things that we change in older patients as opposed to younger patients, we're going to be more likely to replace bones instead of leaving them broken. And the reason we're more aggressive in replacing bones is because replacements tend to allow patients to start walking sooner, lower risk of blood clots, and I think they're able to start functioning sooner. Typically, when we fix, articular fractures, it's 3 months before we start letting them weight bear. Or if it's, other within the shaft, it's, we have to see at least some evidence of bone healing before we start letting patients weight bear. So we tend to be more likely to replace fractures as opposed to just fixing them. And I think importantly, we like to work with hospitalists, not just because and geriatricians, not just because it's convenient, but because it's actually demonstrates improvement in outcomes. And so I think it's really important that we work together. So the type of fixation that we do, and I'm going to pay a little more attention to hip fractures because, again, this is more common. The type of fixation that we perform is dependent on the fracture location. And so, when it comes to hip fractures, there's three basic types of fractures, and it all depends on where the break occurs in relation to what we call the trochanter. So this bump is called the greater trochanter. This bump is called the lesser trochanter. And so when you have a fracture that occurs above the trochanters, that's in the neck region, so we call this a femoral neck fracture. When it occurs, when it occurs within the region between these two bumps, the two trochanters, the greater and lesser, we call that an intertrochanteric fracture. And when it occurs distal or below the trochanters, then we call it a subtrochanteric fracture. And kind of going over the different ways that we might fix these injuries, a subtrochanteric fracture, we might put in a long rod to stabilize the injury. Intertrochanteric fractures, we used to use this type of device to fix these. This is called a sliding plate. Now we tend to stabilize them more with these, either one of these or one of these. These are intramedullary nails. And we'll typically fix it with these in order to provide stabilization from within the bone. When you have the other type of fixation for femoral neck fractures, we'll choose one of actually four options. So all four of these are options when it comes to femoral neck fractures. Typically in young patients, I might select something like this. It's very rarely something like this, but in our geriatric patients, I think about whether or not this bone is completely separated or if it's still partially separated, partially connected, sorry. If it's partially connected, then, or impacted, then what I'll try to do is fix the fracture. And the reason that is because the blood supply to the femoral head actually comes around from the femoral neck and it travels up the femoral neck to the head. And so when this injury occurs, you worry about the blood supply to the femoral head. And if the blood supply dies, then, it's decreased, then the femoral head will die, and then you'll have to do a hip replacement anyway in the future. And so that's why when we're trying to fix these, we really have to pay attention to see whether or not it's a non-displaced fracture or a displaced fracture. If it's a displaced fracture, then I'm going to elect for some kind of replacement. There's total hips or partial hips or hemiarthroplasties. Most places people will choose, community orthopedic surgeons will choose a hemiarthroplasty. The problem with a hemiarthroplasty is that in people who are active, they tend to wear out after 2 years. They wear out up here. And so if you're somebody who's community ambulatory, and this is really why it's important to take a good history, if you're a community ambulator, then I recommend actually doing a total hip replacement. And that way, patients are able to get up and it's the first and last operation for their life. So outcomes, previous fractures are the strongest predictor of a future fracture. And I think, that just indicates somebody has osteoporosis. And if somebody breaks one hip, they're 10 times higher to break the other hip, which makes sense. The one thing that doesn't make as much sense is their mortality rates. We know that at 1 year, in hospital rates are 6%, and then at 1 year, it's 30%. So that means if you have a hip fracture, you have a high chance of dying within that first year. We know that if we operate on people within 48 hours, we can decrease their complications, their length of stay, and their overall mortality. But even if we do this within the first couple of days, they're still at higher risk. And I think this has a lot to do with showing that people, when they fall, are more frail. But we don't really, there's nothing we can really currently point to that quite explains why these patients are dying earlier compared to other patients. men do have a higher mortality rate compared to women when it comes to this. Also, it's important to pay attention to delirium. I think a lot of our hip fracture patients develop delirium postoperatively. So some of the things that we try to do as orthopedic surgeons is minimize how much narcotics we're giving, the type of fixation that we choose, and for replacement is our goal is to try to give patients early mobilization. I think removal of catheters is important. I try to get, all of my urine catheters out because I want patients to be walking. So if I can get them out on post-op day 1, it's important. DVT prophylaxis, I typically like my patients to be on some kind of prophylaxis for about 30 days because it's pretty common, and then pressure ulcers and atelectasis management. And again, I think co-management is really important for these patients. Again, paying attention to osteoporosis. For some of you who may not know as much about osteoporosis, getting DEXA scans and calculating FRAX scores are things that we like to do after surgery. This is not something that most orthopedic surgeons will do. Typically, we hope that the internal medicine doctor is going to do this, or the family medicine doctor is going to do this. But I will say that I think a lot of patients not appropriately worked up for osteoporosis following a fracture. And again, I think the important thing is we measure osteoporosis based on younger patients. So patients who are 25 years old is what we compare all of our patients to with the DEXA scan, and it's defined as 2.5 standard deviations below peak bone mass. The FRAX score, just to touch briefly on this, is a score that's available online easily. It takes into account multiple factors and is pretty useful in determining a fracture risk for hip fractures or other osteoporosis-related fractures. So I think it's a good tool to use. And again, making sure that patients are appropriately worked up for nutrition management, or if their home environment is set up to avoid falling, so making sure that they have railings and appropriate support and no rugs and that sort of thing. So kind of switching gears a little bit to osteoarthritis. So osteoarthritis is really just the degenerative disease to the synovial joints and causes progressive loss of articular cartilage. Hips and knees are by far the most common, and that's really what I focus my specialty on, and I kind of talk to you folks about because I think it's more common than most of the other types. Total hips and total knees, people are experimenting with all kinds of things, such as ivory and resection and all sorts of things. But really, the first total hip, modern total hip, was performed in 1940 and eventually became pretty popular in the 60s. And we expect by 2030 that almost 1 million of these will be performed every year. Total knees, based on the success of total hips, is the next thing that we developed. In the 70s, it really became much more popular, and over 2 million will probably be performed in the US every year at 2030. So the risk factors for osteoarthritis, people in their normal adult lives, their occupations and trauma or sports, plays a role, and large body mass definitely plays a role. As we get older, muscle weakness probably plays a role in how much pain we're feeling. Non-modifiable things such as gender, genetics, and then some of these childhood diseases like hip dysplasia. Most of the childhood diseases actually occur in the hip itself as opposed to other parts of the body. This is kind of a complicated slide, but I think the important thing to take apart between normal aging and osteoarthritis is the modulus of elasticity. And basically what that's saying is that the cartilage in older people tend to be more pliable and softer, whereas in specifically osteoarthritis, it's much harder. And you can kind of think about it as softer cartilage, is normal, whereas in osteoarthritis, there's more pothole, there's more bone on bone. So when bones rubbing together, it's a lot harder compared to soft cartilage. Taking a history of these patients, it's important to look at, how old they are they able to undergo a surgery, or should we try to focus more on non-operative management? Their functional activity, do they have any catching or locking? How stiff are their extremities? Do they experience pain at night, pain with walking? How far can they walk? Looking at how somebody can walk, I think looking at their body habitus is really important. We're moving away from operating on people with a BMI over 40 because of the higher risk of complications in larger individuals. Some hospitals will even ban you from doing any kind of surgery with somebody with a BMI over 40. And getting a good neurovascular exam and skin exam is very important. Sometimes there's other things going on that preclude surgery. When I look at imaging, the non-weight bearing views that are commonly done in the emergency room or a lot of outpatient centers, I don't really look at those because they aren't reliable. And a lot of people will order, will try to do MRIs looking for some kind of cartilage injury or meniscus injury. And I think that that's something that I would avoid doing in the setting of arthritis, because we know that arthroscopies for arthritis and meniscal tears in the setting of arthritis tend to do poorly, unless sometimes they have some kind of mechanical symptom such as catching or locking. So this kind of highlights the differences in a standing APE versus a non-weight bearing view. So what I look for on X-ray is hard surfaces, and that's what you can see. This is a wire from a previous fixation, and you can see the space here, and the space is how you infer cartilage thickness. Well, this is a non-weight bearing view, and you can't really see anything. I mean, it looks okay. When they start to put weight on it, you can see the loss of space over here, the loss of cartilage. And so I think that's really important when ordering X-rays, that you order a weight-bearing view if you're looking for arthritis. Other special views are Rosenberg views. These are right and left knees. A Rosenberg view is really when you bend down and you're taking a shot where your knee is actually bent down like this. And what that's doing is it's putting pressure on the back of your knee, and you can see when you bend the knee that there's lots of space back there. And sometimes we look underneath the kneecap, a normal amount of cartilage on this X-ray. Oh, sorry, I'm pressing the wrong buttons. Oh, okay, I think I got it. And you can see normal amount of cartilage underneath the kneecap, and this is something where you can see osteoarthritis. No space here, and this is actually a bone spur, an osteophyte. We can try to classify osteoarthritis using the Kelvin-Lawrence score or the tonus classification. This is pretty unreliable, though, between providers. So I think the take-home behind this is to look for things like loss of joint space, some bone cyst formation like underneath here, some increased whitening, which is subchondral sclerosis, or bone spurs. And those are the things that we look for. This kind of shows a bone cyst here. But again, it's pretty unreliable across different providers. So I think it's just looking for some of the classic findings. Again, bone cysts, bone spurs, and then the loss of joint space. Those are really what's important when you're looking at X-rays. So the first thing I always do whenever I talk to somebody about arthritis is to look for what have they done non-operatively. And I think it's really important to try to treat these kinds of things without surgery, because some people actually do pretty well and end up not needing any kind of joint replacement. I think naproxen or tramadol or some medications that we try to use, sometimes those are things we can't use for either cardiac reasons or renal reasons or other tramadol. Sometimes I've noticed gives some people weird side effects. So sometimes those are things that I avoid and I might end up using Tylenol. Activity modification, so encouragement of using a cane or a walker. Anytime your BMI is greater than 25, it actually increases the risk of pain and having pain from arthritis. So if we don't notice it much of a difference below 25, but if you're heavier, it makes sense because you're putting more weight across the knee. Every pound on your body is 4 pounds across the knee. That gives you an indication of how much difference that makes. And a physical therapy program to increase strength is important. We try things like corticosteroid injections. Sometimes I could do them every 3 months, and if they last, then that's great. And sometimes we use it when we're not sure if the pain is coming from that specific location. So if somebody has pain that looks like it's from the hip or from the back, and we're unsure, then we offer a steroid injection. And if it improves, even for a short time, then we at least know that that's the area that's causing issue. There's a few other things that are controversial. These gel shots are pretty popular, as well as taking glucosamine and chondroitin. The research for those has not shown that it makes much of a difference. Although if patients ask for it, I think that the harm is minimal, but there's not much evidence that they make a difference. And so if you're worried about costs, those are things I would probably give up first. So when it comes to surgical options, there's a few different surgical options. I'll say that in most older individuals with arthritis, I tend to avoid these two options, scopes and high tibial osteotomies, which is basically a joint realignment, because I think that those are less reliable, and a lot of times you do that and then you do another surgery. I don't think it's worthwhile to go through a surgery that's not going to work very well. There's two, for knees, we look a lot at partial knee replacements and total knee replacements. Picture down up here and down here really show you a partial knee replacement, you're only replacing the part of the knee that's degenerative, whereas a total, you're really replacing the whole knee. And again, here's x-rays comparing the two. With partial knees, people are able to recover faster, and it's becoming more and more popular. But sometimes we worry that sometimes we have to go back and redo some of these. So a total knee is really the gold standard. And I think it's a conversation I have with every patient, what option they're looking for. When it comes to hip replacements, again, arthroscopy is very uncommon in the setting of arthritis, and I really would recommend against it. Some of these other things, like osteotomies, maybe in a young adult, or hip resurfacing, also maybe in a young adult. Those are fairly rare to see. Femoral head resections, those are when we actually just cut out the femoral head and don't even put in a replacement. That's something that we do for very rarely for very sick patients or patients who are non-ambulatory. But by far, the vast majority of these will consider doing a total hip replacement because that gets people up and walking, and it's the standard of care. So the current trends when it comes to hip and knee replacements, with hip replacements, the direct anterior approach is probably the most popular thing. I think that it's something hasn't been, since it's been out for a while now, we've noticed that some people have decreased dislocation rates and earlier mobilization, but I think long-term results are essentially the same regardless of which way you do it. But it is advertised as a muscle-sparing surgery. Knee replacements, partial knees are becoming more common, again, due to improvements in surgical technique. There used to be a high failure rate of these, and I have a practice. I do have some unis, but I have a practice of a lot of unis that were done from elsewhere that need to have revisions. robotic joint replacements is something that's growing. There's not a lot of long-term studies. Most of them are short-term, 5 years, 2 years or 5 years. But we're starting to see some people are able to recover faster with the ability to place the implants more accurately. And the hope is that they last longer. I'll be giving a talk actually at Queens for the orthopedic surgery residency on robotics and the evolution of robotic surgery, because I did a fellowship on that. So I'm going to touch briefly on joint replacement failures, because those are some things that I see a lot of. They're not common, but some people don't. I mean, if you're a young guy, you end up with the things that nobody else likes taking care of. And so, I think it's important to take a look at, some of the problems that can happen. So falls can lead to periprosthetic fractures, especially with patients with osteoporosis. Infection, I tell people it's a 1% risk, regardless of what hospital they have. They have a hip or knee replacement, but if they do have an infection, it can be a pretty big deal, or it is a big deal. The implants can loosen, so I like to follow up on my patients yearly, even if I don't see the loosening till about 15 years or 20 years. And that's really because the implant material that we use, it's made of plastic, and these plastic pieces can wear out eventually. And dislocations can happen. And I think most of these other things are less common, but they can occur. And the reason I bring this up in this talk is because most of the patients that I see that need some kind of revision work, they tend to be older and sicker patients. So, this is a total knee that you can see is dislocated out of place. And this is somebody who had a BMI over 40. And she's 80 years old. Similarly, this is a fellow who's 89 years old who underwent, came to me for the third surgery with a history of infection, a couple of revisions, and inconsequential, but a previous hip fracture that was fixed. And again, this is another 91-year-old guy, with his knee implant. This is his second revision. You can see it's starting to peek out of the bone here. His other side actually has some areas of loosening underneath here, where this one's trying to do what this side is doing. But I bring that up because these patients need to undergo some pretty big surgeries at an older age, and a lot of times I find that they're not, their health otherwise is not very good. So I think it's important to pay attention to their nutrition levels, and these are some markers we can try to use to measure that. Usually I use albumin mostly. Anemia is a fairly common thing I see in these patients, as well as uncontrolled diabetes. Those are, in patients who are particularly sick, I might not try to fix what's going on and advise to continue living with what they got. But sometimes, something like this where the guy was playing golf 1 year ago, it's hard to argue not to fix something like that. Any questions? I'll go from front to back. Oh, sorry. So the question is, what is comminuted? So comminuted is a fracture pattern where there's multiple fragments. So a simple fracture is, where you see, a stick and it's broken into two pieces. A comminuted fracture might be a broken bone where you're seeing 3, 4, or more pieces involved. Question from the back?
For osteoporotic fractures, like this one, after the repair, if they were on a bisphosphonate before, or you want to start one, is there like a certain amount of time post-op that we should be?
So the question is if there was a osteoporotic fracture, when can I start bisphosphonate use? And I would say probably the best thing to do is wait for about 3 months, and that gives it a chance for us to go through the fracture healing most of the time. If your orthopedic surgeon is saying, I'm having trouble with healing, and that would be something called a non-union, then that's when you would still hold off for a little longer until we can get the fracture to heal. So the only caveat is if they had a atypical femur fracture, which is a specific type of femur fracture. It commonly causes subtrochanteric fractures. So this specific fracture pattern is actually associated with bisphosphonate use, because what ends up happening is the way that the bone turns over, it causes a stress reaction right in this region. And when that stress reaction occurs, and sometimes you can see it before the other side breaks. So usually what happens is I see this side broken, and then the other side will actually have a specific type of stress reaction we can see on the bone. And we'll actually do 2 surgeries on the same day or within a week to try to stabilize both bones. So that's, I guess what I'm trying to say is if you have a subtrochanteric fracture and you're worried about previous bisphosphonate use, that's the one time that I would avoid using bisphosphonates.
You mentioned DVT prophylaxis for about a month after surgery. What do you use?
So the question is, what do I use for DVT prophylaxis for the month after surgery? So in most hip and knee replacements, for primary use, I'll actually use aspirin. 81 milligrams tends to be enough to block platelets. Now, in somebody who has a hip fracture or some other type of traumatic injury to the lower extremities, specifically the knee or the hip or the thigh region or pelvis, sometimes you may want to consider something stronger like Lovenox. There's a few other options that are out there, but those are the 2 that I tend to be most familiar and most comfortable with. The aspirin, I've used 81 because I'm trying to avoid gastrointestinal bleeding, but that may be something that some people can't tolerate. So that's kind of the conversation to have. Some of the other DVT prophylaxis options are harder to reverse. Coumadin, I think, is particularly aggressive, but some of the other oral medications tend to be harder to reverse in patients. So I'm a little bit nervous about some of those unless we find a way to reverse them.
In geriatrics, in patients who have had an ORIF, and you can feel the patient's complaining of hip pain, and you can feel the head of the screws under the skin. Is that anything that makes the person needs to have that joint replaced?
So the question is, if somebody has a history of an ORIF and you can feel the screws after surgery and you're wondering if they need to have the joint replaced, that's kind of a more complicated question. So sometimes the answer is yes, sometimes it's no. So, so say it's fixed with either this method, and sometimes with one of these 2 methods. You can actually feel the screws out here or the plate out here where this screw most commonly right here. The caveat, the one problem is that sometimes the pain is actually more from the scar tissue or the incision on the outside right here. And when that occurs, then it's really more about addressing the tightness of your IT band, maybe focusing on your greater trochanter. Sometimes greater trochanteric bursitis, sometimes the muscle was injured up here, your gluteus medius is inserted as you try to insert one of these 2 devices. So sometimes we think about taking out the implants and seeing if that helps. If, when there's a femoral neck fracture and the blood supply down here dies, and either the head dies or the screws start to protrude through there, people actually complain about groin pain as opposed to pain on the outside of the hip. And when you complain about groin pain, that's typically more of a hip socket problem as opposed to the trochanteric or screw prominence problem. And so if it's groin pain, that's when I would think more closely to replace the hip. Kind of the complicated part is some people have lateral base pain that's coming from the hip. And when I'm a little confused about that, then I'll do a steroid injection to try to tease that out. So that's the long-winded answer to your question.
What is the Z score?
The Z, so the Z score. So when we're doing a DEXA scan, we're looking at T scores and Z scores. And so what we're looking for is a bone mineral density. So that's, we're looking at certain anatomic sites and we're trying to compare. We actually come up with two different scores after a DEXA scan. So sometimes we look at compare your DEXA scan versus 25-year-olds or versus other people your age. And so when you're looking at the T score, you're looking at people who are 25 because that's typically the max bone density that you would be when you were younger. Whereas the Z scores when you're looking at somebody who's closer in age. We tend to use your T score for osteopenia or osteoporosis. And the reason we do that is because really what we're trying to do is measure your bone density compared to the thickest bone density that you had when you were younger. I think that's true. I think what you're saying makes sense. The question is whether you're comparing Z score versus T score, and wouldn't it make more sense to look at other people your age? I think that makes sense, but I think the problem is then it's going to be harder to figure out how thin your bone specifically is if you're looking at a lot of people with thinner bones. And if you have thinner bones, then that's really what we're looking for. And so I think the comparison is to be, it makes sense to me to try to compare how thin your bone is today compared to how thin or thick your bone was at the thickest it was when you were 25. So a Trendelenburg gait is a specific type of gait that occurs when your gluteus medius is not firing well. And so what happens is the affected side tends to drop as you walk. And so typically, I can demonstrate it for you. So typically, you kind of drop your hip as you're walking. So it looks kind of like this. So you walk, so it's actually the affected side that kind of drops. So as you step, you're supposed to pull your hip up with your gluteus medius, but it kind of drops like this. So you kind of drop your leg kind of drops a little bit instead of being able to pick itself up normally with a normal gait. That's fine.
A lot of studies show that when you gain obesity and all these risk factors, obesity. Have there any studies showing the quality of height?
Does height make a difference in terms of how much you fall? I'm not sure if there is a study or not, so I can't say that I know the answer to your question. I would intuitively make sense to me that if you're taller, you have a further distance to the ground. So intuitively, if you're taller, you're going to hit the ground a lot harder and be more likely to break a bone. But I don't know if there's a study demonstrating that.
Another question. Do you have anything about the necessity of having bilateral at the same time?
Bilateral total, what's the studies regarding bilateral total knees? So okay, I got your question. So that's a good question. There's actually a lot of studies looking at bilateral total knees. So To answer your question, I think the important thing to know is that there's two things. I mean, there's a few things that run the world: finance and romance, right? And so this is one of the questions that actually comes down to finance. So when you do bilateral total knees, the insurance company pays half as much for the second knee. So that's when you're doing it at the same time. If you do the second knee a week later, 2 days later, 3 months later, it is you get payment for both total knees. So that's just something that comes with billing and surgery. So that makes you have to read all these studies when it comes to bilateral total knees, kind of with that in the back of your mind, knowing that some people are going to have different financial pressures when they're writing their study. So there is definitely some studies that are out there that's showing increased risk of blood loss, infection with bilateral total knees that are done simultaneously. Some studies show that it's not true. So it's really difficult for me to interpret from the data, because every couple of months a new study comes out in Journal of Orthoplasty or some other journal where they're talking about bilateral total knees. So I don't really have the right answer when it comes to that. I think with bilateral total knees, the benefit is that you can recover faster. You may be able to recover faster because you're only going through surgery once, but it's going to be a harder recovery. So basically what I tell patients when they come in and they're asking for bilateral total knees, I say, hey, look, we don't know if it's riskier. It might be. But if you're going to choose between the two, on one hand, you may go through surgery and get it all done at once, but it may be harder to recover. Or you can choose to delay them and see how well you do with the first one, and then choose to do the second one 3 months later or at a time that's more convenient. So really, I would just let my patients decide what they want to do. I tend to pull patients away from doing bilateral simultaneously because it makes sense what you're saying, that it's riskier, but the studies are really controversial. And so I tend not to push patients really heavily in one direction or another. It is cheaper to do bilaterals for hospitals. So it depends on if it's hospitals or surgeons writing the study. Thank you.